Again, this is the Adult Cardiac Surgery Database Quality Improvement Series on decreasing blood usage. Today's December the 18th. We have Dr. Amanda Rea with us today from the University of Maryland, St. Joseph Medical Center. She's going to present a talk on patient blood management. This is going to be a really good talk, and I'm so excited to have Amanda with us today.
Thank you so much.
So here's our agenda. So we will have a welcome and introduction, some updates, and then we'll get on with our program. On the call today from the STS, we have Carol Crone, Emily Conrad, Paul Meehan, Leanne Jones, and Addie Dolan. And then we also have Melinda Offer on with us today. And then like I said, we have Amanda Rea from the University of Maryland, St. Joseph Medical Center. We'll get started really quickly and move through these updates so that we have time to listen to Amanda. Just a few quick updates. The Harvest 3 2024 reports will be available to you by Monday, the 23rd. And the only other update I have are some important dates, and we'll get to those in a minute, but I'm going to go ahead and turn it over to Paul. He has a few updates for us.
All right. Thank you, Nancy. I just want to talk to everybody real quick about the new risk scores. We have the new updated models. We have the new PROC IDs. And all that, and you're starting to see that in your reports, and you're seeing all the information about that. But everybody is asking, okay, when am I going to see that in my vendor software? And I've gotten a lot of reports from the vendors saying, hey, we haven't heard anything. Am I missing something or anything? So just to keep everybody on the same page, the vendors have not been given anything for the new risk scores. So it's not the vendor's fault. So what is the obviously making the updates to the risk models, coming up with the new scores and everything was a lot more intensive than was originally planned. And so the focus of the time and energy was put into getting those completed and incorporated into the analyses and the reports. Now we're working with how are we going to get this out to the vendors, and what we're trying to do is come up with a better way of having the scores calculated. So we're playing with a lot of ideas. What we're hoping to do is come up with a solution where your vendors actually aren't calculating it. It's being calculated by the STS. Even though it's showing up immediately in your software. We're hoping to go with that method. And the advantage of that is the whole issue with the coefficients having to be updated. You won't, you'll get values that are, up to date, and like the latest and greatest coefficients are being applied and stuff with every single record that you see. So that's what we're hoping for. We're finding that some vendors that doesn't really work with their security models and stuff like that. So there's some tricks and obstacles that we have to get through first. So please be patient with us. We know it's important for you guys to have that information in your software. We're doing what we can, but it will be a little while before we get the solution determined. Then we got to get it programmed, and then we got to get the vendor certified, and then it needs to get rolled out to you. So it'll probably be quite a while before you actually see those scores in your software. But just do know that we are working as fast as we can, and please don't be, giving your vendors grief. They're doing everything they can too. So we'll try to keep everybody up to date on the progress that we're making there. So that's all I want to say about that. On a separate topic for help desk, I also wanted to kind of reiterate, Banu and I gave a presentation in one of our the previous webinars about the best way to work with help desk. We see that a lot of people are taking our advice into account, and we appreciate that, but we do still see some people sending emails to everybody that they know at STS with their questions and stuff, and or sending a question and then a couple hours later sending a follow up. What's happening. Where's the solution? Um, that just kind of a reminder. We need, please give us 2 days before we ask you to give us 2 days, even though we normally get the questions answered within one day. But do give us 2 days to get a response back to you before you start sending more emails. When you send more emails, it actually slows the process down because it's more overhead that we have to deal with then. And also don't send emails to everybody and their brother. There's the STSDB_help desk. That's your go-to help desk. And I'm going to type that out into the chat there. But that's your go-to. Send it there. Don't send it to everybody else. Everybody else has other stuff that they're working on to try to get done for you. And again, it just slows things down, or people start forwarding it around to try to make sure it's getting to the right people. And, next thing you know, you have 3 people stepping on each other, trying to help you out, and actually just making things worse. So again, just put it to help desk and nobody else, and give us 48 hours. So that's just my reminder, and thank you very much. Turn it back to Nancy.
Thanks, Paul.
Mhm.
I appreciate that. Just quickly, some important dates coming up. Today is the 18th, the blood usage webinar with Amanda Rea. On Monday, the 3rd, or the Harvest 3 reports will be distributed. Next week, STS will be closed December 24th, 25th, and then again on December 31st and January 1st. So happy all holidays to everyone. And again, today is our last webinar of 2024. Our next webinar is January the 15th. This will be a quality improvement webinar on blood usage. We do not have a speaker for this webinar yet. So if you have a project that you would like to share, please get in touch with myself, Nancy Honeycutt, or Carol Crone, and let us know. We would love to have you share your ideas, your progress, your projects, anything that you have around blood conservation. We would love to have you. January,
Jumping in here. I'm jumping in here, Nancy. I'm jumping in
okay.
here. So, sorry for that, but I really want to put a call out to those that have done blood conservation projects at their hospital level or within the state collaborative. If you're part of a state collaborative and you've done this project as a state collaborative or a region collaborative, we would love to hear that project too. I know this is a big topic at hospitals, so I know these projects are being done. This is your chance to highlight what you've done, your successes, your challenges, and to share it with your peers at the STS to improve the care of our patients across the nation. So please consider reaching out to Nancy or myself. We would love to have you. I promise you, it's not scary to present on these webinars. We have a great group, and we really want to hear what you're doing at your sites to get that information out. Thanks.
Carol. Let's see, where were we? Oh, January 24th through 26th is the STS annual meeting in Los Angeles. And then on February the 5th, we will return to our normal webinar schedule, and we will have our ACSD monthly webinar on February 5th. So with that, those are all the updates that I have. Carol, do you have anything else?
No, I don't have anything else, Nancy. Thank you.
Okay, perfect. Thank you. All right, we will get on with our program. Today, we're delighted to have a guest speaker, Amanda Rea, DNP. She is the Advanced Practice Lead at the Division of Cardiac Surgery at the University of Maryland St. Joseph Medical Center, and she is going to speak to us today about patient blood management. So welcome, Amanda. We're so happy you're here.
Thank you so much, Nancy. I want to thank Nancy and Dawn Roach, my data manager, for plugging me in to bring me here to speak to you guys today. So I guess let's just get right into it. Go ahead and go to the first slide. So my disclosures are that I speak for Edwards on goal-directed therapy, but not really pertinent to this talk. And I'm on the advisory board for the ERAS Cardiac Society, and actually with you guys do the critical care workforce, which is actually being rerouted to other things, but been doing work with them as well. All right, so how I'm going to go through this talk is I'm going to talk about patient blood management as part of our ERAS program and how we've incorporated that. And then what the process is here at St. Joe's, and then I'm going to talk to you a little bit about our results. So enhanced recovery, just for those who don't know, is an adjunct to a standard of care. So standard of care is you bring somebody in at their baseline, they have the insult of surgery, and then with standard of care, they're worked to rehab up to a new baseline. And then you can go to the next slide. With enhanced recovery, the idea is that you sort of prehab them with whatever time you have to get them to a higher baseline before you have the insult of surgery, and then use enhanced recovery protocols to rehabilitate them and have them either at a new or above that baseline. So it optimizes the patient pre-op, it minimizes the stress of the surgical stress, and gives them a faster recovery. So as part of our program, this is a picture of one of our cardiac surgery ICU nurses walking somebody. She had surgery in the morning. This is in that evening of her walking the unit. And so we kind of have incorporated a bunch of the elements of enhanced recovery. And then even before it was really in the guidelines, we had utilized patient blood management as part of our program. This is, if you see here, if you click it one more time, there are, we have this hanging in all areas of our hospital that do cardiac surgery. And so it's so that each element can see, maybe you're siloed in the pre-op area or you're siloed in the post-op or the intra-op area, but it's so each piece can see what they bring to the table to kind of bring out the whole perioperative journey for the patient. And so obviously using pre-op anemia and treating that, and we'll talk about that in a little bit, and then having blood conservation in the intra and post-op period is all part of our ERAS pathway. The most recent guidelines were actually distributed. So the original guidelines were published in 2019 in JAMA Surge. And then in conjunction with the STS, the ERAS Cardiac Society published this at the STS meeting, actually launched it this past year in January. And this year they actually added patient blood management as part of the guidelines. You can go to the next slide. In part of that, and in conjunction with talks that we gave at the STS or AATS, they started coming up with these turnkey order sets. And basically it's looking at multiple guidelines. You can go to the next set, and creating them into what you could look at as an order set like this, that you could basically print out and give to your Epic people or whoever builds your order sets, and use what pieces work for your hospital to try to create different types of order sets. And there's patient blood management and multimodal pain and different types of, there's like 6 of them at this point, and we're continuing to build more. Next. So how we got to these set of recommendations instead of just randomly picking what we do, we looked at the major guidelines within each thing. And so for the patient blood management, we looked at the STS, SCA, and AMSEC guidelines. We looked at EACTS guidelines. We looked at the ASA, and then the POCI and ERAS cardiac consensus statement. And we looked at things that were either grade 1 or 2A. And then we looked at if they were in multiple guidelines instead of just being an outlier. And then that's how we chose if we included them in that turnkey order set or TKO. So if you look by phase of care, kind of how it leveled out was, and we'll go into this a little bit more in a few slides, is basically taking some platelet aggregation studies or viscoelastic testing to help you time surgery appropriately, and screening people for anemia and treating that. and then having some sort of threshold for hemoglobin in the operating room and after and post-op area. And then using things in the operating room like antifibrinolytics, cell saver, and wrap. And we'll talk about that a little bit more too. So if we look at patient blood management, what does the literature say about it? And there's plenty of literature that sort of says that, of course, people who get blood do worse and have worse outcomes because they're sicker. But there's also several studies that sort of debunk that. So the largest randomized control trial that comes with patient blood management and cardiac surgery is the TRICS-3 trial. It was initially published in New England Journal of Medicine in 2017, and they actually then did a follow-up 6-month study. And they looked at a restrictive strategy versus a liberal strategy of transfusion. And the restrictive strategy was a hemoglobin of 7.5, while the liberal strategy was a hemoglobin of 9.5. And they used that intra-op and in the ICU, and then used 8.5 in like the tele floor. And they found that a restrictive strategy is not inferior to a liberal strategy, meaning that their outcomes were no different in their primary of mortality. And then they also looked at secondary outcomes, looking at vent hours, ischemia, low cardiac output state, kidney injury, and like encephalopathy and delirium. And so that at least helps prove that a restrictive strategy is at least no more, it's not as harmful, not harmful to the patient. And you can move to the next one, sorry. So this study was published in the Annals of Thoracic Surgery in 2022, and this looked at a composite of how the mortality of a patient was linked to each packed red blood cell or a non-red blood cell unit. So they looked at multi-center, 24,000 patients, and looked at 30-day mortality. And with each packed red blood cell, a patient had a 13% greater risk of mortality, and with a non-packed red blood cell had a 6%. So that kind of helps people think about when you're going to transfuse somebody and they think, oh, well, I've sort of already like, burst the thing. I'm going to give them a unit, just might as well give them 2. That's probably not the best strategy. If they only need 1, give them 1. This looked at pre-op anemia sort of versus blood transfusion. And so this was published in JTCDS and looked at about 33,000 patients. And they found that packed red blood cell transfusion, not the hematocrit value, so not anemia, because we know anemia is bad, but it doesn't appear that transfusing patients really mitigate that risk. And so they found that the transfusion, not the hematocrit value, demonstrated stronger associations with post-op mortality, renal failure, and stroke. So again, anemia is a problem, but it doesn't seem like transfusing someone that's obviously not actively bleeding is necessarily the answer. So I'm going to talk to you about the pillars of patient blood management that we've utilized here to have success in having a restrictive strategy and program. And so the highlights of them are the pre-op, you need a multidisciplinary approach. We're going to talk about treating anemia and platelet aggregation studies for preoperatively. Intraoperatively, you need to make sure you have a meticulous surgery, use of antifibrinolytic cell savage, wrap, and have a trigger. And then postoperatively, have a trigger and create that culture of conservation. So we're going to go into each one of these a little bit. So when we talk about having a multidisciplinary approach, the first thing is recommended by most pertinent guidelines and societies. And you want that to be a formal group that's usually at a hospital level. You want to keep your decision-making team small but multidisciplinary. You should include nursing and surgeons and anesthesia, intensivists if you have them, advanced practice providers, residents, definitely your blood bank director. And you create this group, you guys look at the literature and create a standardization and agree on a process before you start rolling out and educating your team. Managing pre-op anemia. This is just a screenshot of our, at my institution, what we do to treat pre-op anemia. So just to make it easy, rather than using the 12 and 13 of hemoglobin that's in the literature, we just kind of went, if anybody's hemoglobin is less than 12 preoperatively, then this is for an inpatient. We do some iron studies, and then we treat them with IV iron, folic acid, vitamin B12, and 1 dose of EPO. And we use whatever time we have. So there's some studies that show even EPO is helpful even a day before surgery. Now for the outpatients, we do these things except for the EPO, and that's because of lack of insurance coverage for that at this time. but they still can go get an iron infusion at like sort of like our outpatient type of clinic that also does like LASIK strips for heart failure, and then obviously can get the PO medications. You want to time surgery appropriately. So we all know that generally like anticoagulants and antiplatelets are held preoperatively. But the effects of those drugs can vary despite that there's standard guidelines for it. So using some way, either a platelet aggregation study or a viscoelastic testing to kind of test what residual platelet of the medications left and how much platelet dysfunction or anticoagulation that you have in the patient to time the surgery appropriately is key. Now, obviously, this is not always an option if somebody is an emergent surgery, but most of the time, even somebody who's like an urgent elective, you can buy them time enough to do this. Having a meticulous surgery, carefully opening, having a methodical routine for closing, and then there's use of a checklist. If you want to hit the next slide. In Maryland, the checklist that our MCSQI, our quality initiative, of the cardiac surgery programs had kind of came up with several years ago are checking the neck, the otomies, the mammary, cannula sites, the diaphragm well, wires, proximals, the pitted spare, and the mammary bed. And this can be done very, very quickly for the surgeon. Use of antifibrinolytics are pretty standard, and they should be administered unless it's contraindicated for the patient with an allergy or something of the like. It has been shown to reduce blood infections. It's also been shown to decrease incidence of re-op for bleeding in the past. Use of cell salvage is also a main recommendation by most guidelines, and it decreases the need for red blood cell transfusion. And for those that maybe aren't quite medical on the call, this is basically where they suction the blood in the patient and it is spun down into a machine to sort of get rid of the waste and make it just solid red cell transfusion, and we give the patient back their blood that they've lost during surgery. And this has been, they have these results that it's decreased inflammation and the need for blood transfusions and in multiple cohort studies, and then also in a Cochrane review. RAP and VAP is when you take the bypass circuit, which is normally primed with IV fluids up to almost 2 liters, which could decrease somebody's like hematocrit dilution up to 30%. And what you do is when they are cannulated, you back prime that pump with blood so that you're not giving an extra 2 liters off the bat to a patient. And so that's called RAP or VAP. And it's a class 1 recommendation with STS, SCA, AMSEC, and SABMs for PBM. Having a hemoglobin trigger. Now, our hemoglobin trigger here is pretty probably, I would say, perverse for most people. It's a hemoglobin trigger of 6 intraoperatively and postoperatively. But setting a trigger would automatically decrease your blood utilization if you don't have one. And that could be something as simple as 8 or 7, but having some sort of standard where everybody is in agreement on the same thing instead of having variation in care will likely improve that for you. So there's multiple studies that have shown a low hemoglobin trigger is equivalent and sometimes superior to more liberal blood transfusion. And so you have to have anemia tolerance. That's probably one of the biggest things if you're going to take away this, is that there isn't any literature trigger that has been defined. TRIX is the closest thing we have, and that's shown that 7.5 is safe, but it's likely lower than that. And so instead, you need to look for physical signs of inadequate perfusion. Lactate, bumping creatinine, dropping urine output, low blood pressures despite, treating everything else. And then you have to have a culture of conservation. So you manage it like a change project. Once you have your decision-making team, you recruit key stakeholders, champions in different areas, nursing, advanced practice, the docs, whoever's part of the process of identifying someone who needs transfused and transfusing. And then you assess your variabilities and your gaps of care and your existing protocols and what their knowledge base is about transfusion versus anemia, because those are different things. And then you want to look at how you screen people preoperatively and what your transfusion rates and what your stroke rates, renal failure rates, and your re-exploration rates are. And then you kind of create motivation for change. And usually that's for program savings and for improved quality of care. Once you kind of created that environment, you have like a cultural shift that starts showing with your providers. And if you have difficulty, you can also benchmark your peers against each other. You can either do that by a de-identified way or identified way, to where that person knows which one they are, or everybody knows who everybody is, because a little competition certainly can get people motivated. And then you want it to be that blood transfusions for people who are not actively bleeding are like a thoughtful decision, that they need improved oxygen delivery or perfusion, that blood is going to solve, not just because it's a certain number. So just in review, your kind of 7 pillars that come with patient blood management are having a multidisciplinary approach, treating pre-op anemia, timing your surgery appropriately and having a meticulous surgery, utilizing cell salvage and RAP and VAP, having a hemoglobin trigger, both in the OR and postoperatively, and then creating that culture of conservation. So I thought I'd bring another study to you guys to show you. So in our Maryland Cardiac Surgery Quality Initiatives, it's all the programs in the state of Maryland, and we get together and we de-identify our data and benchmark each other against. And so the center with the highest blood usage came to us because they knew we were the center with the lowest. And we did a study to kind of see what drive that variability. And this was actually done by a medical student, led by her with the help of myself and my surgeon and a couple other people. And we looked at how much hospital H, which was the high transfusing center, versus hospital L, which was the low transfusing center. And so hospital H was transfusing about 36% of their patients, and hospital L was transfusing about 12% of our patients. And we looked at hemoglobin of 7.5 in hospital H was transfused 27%, versus in hospital L only transfused 0.9% of patients who had a hemoglobin greater than 7.5. And the sole reason that people were transfused in hospital L for a hemoglobin greater than 7.5 was actively bleeding. So we found that there was a highly, in L, how it was successful, there was a highly restrictive protocol. There were narrow indications for transfusion, and we had high compliance by our providers. And those, and again, main points by phase of care: managing pre-op anemia, minimizing your blood loss, and tolerating anemia. This is some of the data from my institution going from like 2018 to 2023. So intraoperatively, we've transfused between 1% as high as 2.9. This year has been 0.7 to the, or I'm sorry, in 2023 was 0.7, where a like group for STS is around 18%. Postoperatively, we're transfusing roughly 10% of our patients, and the like group is around 25%. And whenever we show people our data of how low our transfusion rates are, they want to know, well, then what's your renal failure rates? What's your stroke rates? What's your mortality rate? And so our renal failure rate has been around a half to up to almost 1.9 the year of COVID, but roughly around 1 to 1.5%. And the STS benchmark for us is 1.8. And with stroke, our STS benchmark is 1.4, and we are either that or lower every year. Mortality is the same. We're around 0.5%. And then we have a STS-like group for about 1.4. So help proving the fact that a restrictive strategy is at least safe to do so, that it doesn't seem to mitigate, again, risk of anemia, but transfusion doesn't seem to mitigate that. There's also cost savings. I know clinical people, we care about this, but not as much as we care about what happens with the patient. But it is important, especially when you're trying to convince administration of things. So we looked at, prior to us having blood transfusion, so we looked at 2014, and we sort of implemented it, not as heavily as we have it now, but we had a trigger that wasn't quite as low. But from 2015 to 2017, looking at how much blood we saved, both red blood cells and like plasma type of products, and it was over $1 million in savings, $1.4 million in savings, looking at how much money we saved, looking at 2014 as our baseline. And I have the cost here listed at the bottom, like for how much we used for cost for reference. So the take-home points are: a restrictive strategy for patient blood management at least gives you equivocal outcomes, plus savings. And looking at trials, that hemoglobin of 7.5 is definitely safe for a patient, but actually that's likely a lot lower. We just don't really know what that trigger is. If anybody has, I'm always happy to share anything I have, our order sets, any data, anything we have. So if anybody has any questions, you can feel free to email me to get that ERAS information, whatever it is you'd like.
Thank you. Excuse me. Thank you so much, Amanda. That was a great presentation. Our data managers love it.
Yeah,
Getting all the love there.
Oh, that's so nice.
yeah, great job, Amanda. This is Carol again. Before Nancy dives into questions, can I just ask something about your cost savings related to, and I don't know if you have this available or not, and if not, that's okay. But cost savings related to case mix. So I'm assuming probably, I don't know how many, and you may have already presented it. I had to step away for just a second, but what's your volume at your hospital, and do you know the average case mix?
Yeah, so this is the case, this is for cab only, the case cost savings here. We do about 600 pump cases a year. Probably around 350 of them are cab only, and then the rest are a mix of valve, combo, dissection. We don't do VAD or transplant here, but we will do ECMO, we'll do other things.
Okay, thank you. Yeah, the great presentation, and just, I know we don't care about money saved, but, or, we don't often focus on money saved when we're in the nursing position, but in the quality position, that's a big part of how you get projects started, how you can support them, and how you get your stakeholders to buy in, because at the end of the day, that's what we need to be focusing on, so we can bring our healthcare system back to a reasonable, substantial, or sustainable place. So that's very helpful to see, and thank you for sharing that.
No, absolutely. I mean, I think it's helpful, right? Because if we save money in one place, but something else with the program needs financial backing for something else, it's always good to know whatever quality blood management, whatever it is, if you can connect your data and your improvement in your clinical outcomes to cost, it'll help you be able to, leverage yourself to get the things you need for your patients.
Absolutely. Great job. Thank you. And I'll let Nancy go now. I always step in at the first part and am selfish and get my questions answered. So I'll let Nancy take it now. Sorry, Nancy. Thank you.
Thanks. Thanks, Amanda, and thanks, Carol. We're going to open up questions now. I think we'll take the blood questions first and then circle back to the other questions that we have. And please put your questions in the Q&A. So the first question, Beth, has a statement: the studies can't do causation because giving versus not giving 2 units of blood may not cause more mortality. It may be that sicker patients needed 2 units of blood instead of 1.
Yes, that's true. That's what the argument always is that
Mhm.
people who are sicker need more transfusion. When this, there are a couple studies out there that looking at people who are not actively bleeding, looking at people who are just having anemia, and looking at the hematocrit value versus transfusion. And those studies are the ones that have kind of shown that the blood transfusion for somebody who is not having organ perfusion difficulty or oxygen delivery issues, that transfusing those people. So I'm not talking about somebody who is actively bleeding. Somebody who's actively bleeding definitely needs to be transfused. But somebody who is sitting in a chair in a unit, maybe feeling a little tired, with a hemoglobin of 6.4, shouldn't just be transfused to have a number of 7 or 7.5 or even 8, because we're actually doing more risk to them. I mean, some docs I've worked with even call a blood transfusion a transplant, like how you transplant an organ, because of the surge response and the catecholamine response that happens when you're transfusing someone. And so that's are the downside effects of the transfusion that actually doesn't mitigate the risk of anemia.
That's a great point. I don't think people think of it like that, Amanda. Next, Beth says, asked, do you find that using these guidelines that you no longer give red blood cells?
Yes, we very minimally. I will tell you, very rarely do we give a unit of blood unless someone's actively bleeding.
All right. Sue is asking, what is the difference in risk value on the patients in each hospital in the study?
So it was risk adjusted. The other hospital is a hospital that does transplant and things like that, but we did not include those patients as part of the study.
Okay, thank you. And that was Beth's question, sorry. The questions move around on here.
Yeah, we picked a similar demographic and clinical types of patients and benchmark those against each other.
So Sue's question is, in the big picture, does the length of stay increase by not giving blood if the patient is stable at 6.5 to 7.5?
No, it is actually decreased our length of stay. Our average length of stay is about, Dawn probably knows better than I, but it's like 7.8 or 8 days, I think is what STS sort of averages us to be, and we're 5.3 per cab.
That's awesome.
We send a lot of people home on post-op day 3.
Very good. Very, very good. All right. There's a question about, are the transfusion rates just red blood cells for the STS data? And I believe, well, I know intraoperative blood transfusion and postoperative blood transfusion includes all of the components. It includes red blood cells, FFP, platelets, and cryo.
It does. The data I have here, it was just red blood transfusion, but we also track and have low platelet usage and low like plasma, all that usage. We're usually about half of what STS requires or gives us a benchmark of. I would say somewhere from looking at the data, I think around 15 more people get 15, probably 15 to 20% is our average of people who get some sort of coagulopathic FFP, platelets, cryo, something like that. But that's an area that we've been working on too more recently to try to reduce as well.
Is the patient blood management data from the 2018 to the 2023 timeframe focused on cabbage only?
Yes.
Thanks.
It's the most easy. So looking at like double valve or triple valves, or those are a smaller number, obviously, at least here for us. And it's harder to benchmark them against each other because they're very different, like having a triple valve versus a double valve or AVR cab, and STS has so much more rich data when it comes to cabbage. So it's easier, that's an easier group to look at. So that is a cabbage group, yes.
An easier group to look at, but your projects and your
Or everybody.
order sets and everything apply to everyone.
Correct. It applies to everyone. But when you're pulling data, and I don't have a big research, I'm in a community hospital, so we don't have a big research team that I can say, you know, can you get me this? Dawn Roach, our data manager, has really done everything when we look at data, has causes her extra bandwidth. And so we're really trying to be very cognizant of what we ask of her. And she does a great job with that. But because I don't have a big research institute, like if I could ask somebody and like have a shopping cart and say, hey, can you boil down my AVR cabs, my mitral cabs, and my double valves and my this, and tell me what theirs are too, I would love that. But we don't have those resources here. But we do practice the same no matter what the surgery is.
Great. Jennifer says, great presentation. Thank you. Judy's asking, do you do A&H for any of your patients?
No, not most of the time, no.
Can you clarify what A&H is for anyone who's not familiar?
In the operating room, there's different types. I'm assuming she's talking about like antifibrinolytics and oh no, she's talking about acute normal. Yeah. So if you have you want to reduce bleeding for transfusion after cardiac surgery, and you can transfuse like antifibrinolytics, which would be like TXA, and things like that. But you're just trying to have reduce your hemodilution is basically what you're trying to do.
Thank you. Okay, Sue is asking which is better, tranexamic acid or Amicar?
We use TXA mostly. I don't have a lot of experience with the other, but I think that maybe it's probably mostly just hospital specific and cost and what people can get. I don't know if anybody else has experience with using both. We've pretty much had TXA ever since I've been here. I've had very little experience with Amicar on one-offs for people who have had problems or allergies to TXA.
Yeah, at my facility, we used Amicar.
So what's your
Specifically.
experience? Do you have good experience with Amicar?
Yeah, we had good experience with Amicar. Molly is asking how many CV surgeons participate at your facility?
All of them. We only have 3 and they all participate.
I think you kind of have to have them all on board to be
100%.
successful.
And whenever we roll something out, so that's kind of like our ERAS philosophy, not just a patient blood management philosophy. When we're going to roll anything out, we sit as a group and we make a decision. And, you know, sometimes people compromise a little bit. And so we have to be in agreement before we roll it out to the group, because I think that there's been enough studies to look at standardization of care across the board, no matter what you're talking about, and the difference that makes in your quality of care. So, you know, anybody who worked in a unit maybe 20 years ago had a binder and you had how your 10 different surgeons or your 10 different docs like things or did things and how they wanted things ordered. And there's not the same level of experience when you're talking about the bedside nurses and bedside providers at this point. And it's easier if you only have to teach them one way and they're more competent and you have less variation, less errors if you don't have to remember how 5 different people do things. And so before we're going to roll anything out, we sit together and make agreements of what that's going to be before we roll it out to that frontline team.
Yeah, I think it's also helpful if you stand together as one united front when you have consultants and other specialties coming into the unit, and everyone knows what to expect with regard to blood conservation and your hemoglobin triggers.
For sure. I had a PA, she's retired now, but we had a new attending come in the ICU. And for us, we're an APP-led service and the ICU is a consult service for us. And so the attending who was like moonlighting came over to her and she had like ordered blood without talking to anybody from cardiac surgery. And my PA was like, my nurse came to her and was like, somebody ordered blood. And she was like, yeah, we're not going to give that. And so, you know, the attending kind of gave the I'm an attending speech and my PA was like, well, that's fantastic, but that's not how we practice and we're not going to do that. And so the surgeon was very happy to call and correct that. So again, united front, right? And so bringing that message to people, you know, and letting everybody know that everybody's on the same page makes it a lot easier to have a standardization and for people to be compliant with it.
Mary says, excellent presentation. Could you please review the pre-procedure anemia treatment? Let me see if I can go back to that slide.
So for us, there we go. I was gonna say, I'll start talking. So when a patient, either pre-op, outpatient or inpatient, we get consulted on them. If they don't have labs, obviously we're ordering labs. And then as an outpatient, they're getting labs ordered too. So once we get those labs back, if their hemoglobin is less than 12, then for us, we send iron studies on them. If they have an occult or if they have a stool, we get an occult blood, but that's not going to hold us up from surgery if they don't, you know, have a bowel movement. And if they have a positive, then we usually will consult GI and GI will see them beforehand to tell us kind of the risk benefit. and usually that's symptomology with the patient. If they would need a colonoscopy before surgery, which is very rare, that would be somebody who like says like intermittently is having bright red blood stools, like just a little bit of blood. Usually they'll just refer them for an outpatient consult. But it's probably help us on those few people prevent having somebody who has a large AVM and heparinizing them on the table. So we will do the iron studies, start treating them, and then we order them to have the IV iron, and then we give them folic acid, the vitamin B12, and then we give the 1 dose of EPO. And like I said, as an outpatient, EPO is not covered, but inpatient, we can make that happen. So the outpatients get everything else and not EPO.
Very good.
And we won't really delay surgery either. So like if if they can only get 1 dose of iron and 1 dose of EPO, that's what they get. We don't hold up surgery for it, but you use whatever time you have to treat it.
Jen is asking, do you have a protocol for how frequently you recheck hemoglobin and hematocrit on a patient who's low?
It's usually just daily, and unless there is a concern for another reason. Even someone who's low, we check them daily, obviously, unless they're actively bleeding or unless there's another concern like low blood pressure or low urine output or something like that.
Did you note any impact on ICU times as transfusion became more prohibited?
Yes. So average ICU length of stay for us is slated to be like 80 hours or 82 hours, and ours is around like 43 hours, give or take. But most of the time, our patients, I wouldn't say most of the time, I would say a decent amount of our patients are able to get up and go out the next morning to our step down. So yeah, I think we also saw less prolonged vent with giving less blood.
Do you use Kcentra?
No, not generally. We have used, we just usually will we've given it once or twice for somebody who absolutely needs to go right away. But most of the time we just let the Eliquis, Plavix, whatever it is, wash out. We have used obviously like Cangrelor as a bridge for somebody who has a very fresh stent or a reason why they can't really have an antiplatelet. So we'll let them wash out while they're on Cangrelor and then turn it off an hour before they go to the OR.
Judy was clarifying autologous normal volemic hemodilution. Thanks, Judy. Let's see. Oh, we have Melissa is wondering, do you use Epic?
Yes. We use Epic.
Have you seen an impact on your reoperation, either positive or negative?
Yeah, I mean, I think it's probably slightly lower. We've always been below benchmark. It's a little hard to tell. So we had additional surgeon come for a little while that was a little bit newer. So I think not that his skill was actually really good, but I think his comfortability with maybe waiting something out that a more senior surgeon would have waited for. So there was like a bump for like a year, but other than that, we've had probably a decrease overall in reops.
One of the data managers said, great presentation, thank you. And Crystal, do your CABG patients come to ICU intubated, and do you know your average extubation times?
Yes. So our patients do come. We don't extubate in the operating room. Our anesthesia team just doesn't really buy into that. And I don't think the ICU nurses buy into that either. I think there's probably a very small subset of patients that would be okay for, because the places that I've talked to that do it kind of seem to not love it. Seem to think the patients are a little bit more difficult to manage in that first hour or so. And if you look at studies, there's not a lot of difference in somebody who's extubated in the operating room versus their length of stay and all that versus somebody who's extubated 2 or 3 hours. And so we do extubate. Our goal is to extubate within, and so this is CAB only again that I have the data for because of the STS. And we somewhere between 80 and 85% is what we extubate at in 6 hours.
Perfect. Thank you. Molly is asking, do you use TAG?
No, I wish we had TAG. We do not have TAG. We use platelet aggregation studies. And then if somebody's like coagulopathic, we'll send like that. We'll send a fibrinogen, we'll send a PT and PTT, and then just treat off that. And if for those that don't know, platelet aggregation studies are, it gives you like the total number of platelets, and then it gives you a percentage of how many of those platelets are actually functional.
All right. I'm not seeing any more blood conservation questions coming in. If you have any, please send them in. Otherwise, you can reach out to Amanda. She provided her email. You can also reach out to myself or Carol. Let's see, we had a few general STS questions. Let's get to those. So Heather, does this mean our risk scores we submitted for Q3 won't match the new risk scores since our vendor isn't updated yet?
Yeah.
Paul?
Yeah, I can take that.
Mm.
So you don't have to worry about your risk scores because actually when the analysis is being done, everybody's risk scores get completely recalculated by the STS. That has always been the case for decades. So we don't use the score that you have in your vendor software. We recalculate it to make sure everybody's on the same page when we start comparing one site to another. So that I think that's a non-issue, and I hope that answers your question.
All right, thanks, Paul.
Mm-hmm.
That's helpful. Let's see. Shuin, I'm sorry I did not attend the webinars. Please tell us about the frailty test information. Frailty is still on hold at this time. We're working on trying to come up with something that is not so much of a data collection burden on data managers and sites. So no updates on frailty at this time. Michelle says, thank you for sharing. Yes, Amanda, thank you for sharing with us today about patient blood management. And then Molly wants to know Amanda's email. I can type that in the chat box for you. Anyone have any other questions while I'm getting the email?
I can type it while you so you don't have to look for it.
Oh, okay, perfect. Thank you. All righty. Amanda's email is there in the chat box. Thank you so much, Amanda. That was a very, very informative presentation. And I know that all of the data managers enjoyed hearing from you today, as well as all of us at STS.
Thank you so much for having me.
Yeah, great job. Thank you, Amanda. Thank you very much on behalf of STS.
Thanks.
All
I guess
right.
I'll see you at the meeting.
See you at the meeting. See you. Are you going to LA?
Yeah,
Are-
I have
what-
a talk on pressure ulcers.
What day is it on?
I think Saturday. I haven't.
Okay.
That's January. I have no idea.
Nancy and I will come find you.
Okay.
Yes, we'll come look for you.
Yeah,
For
thanks
sure.
again. And
Yep.
safe travels and happy holidays, everybody.
You too.
Thank you.
All right. Thanks, everyone. Thanks for joining.
Excellent call, Nancy.
Thank you.
Great job.
Thank you. Bye, everyone. Happy
holidays.
holidays.
Bye.
Bye.